This week on the BackTable podcast.
I think taking the pieces and the strengths from those around you and learning from them is so, so important. And I think I've become a better leader because I don't just rely on one mentor or sponsor. I'm looking at those around me and I'm saying, what do they do well? What are their skills? What can I learn from them? But importantly, how can I help them too? It's a reciprocal relationship. And that's how you kind of foster that growth is sometimes, they need the advice or the next step, and you can be that phone a friend. And that's really allowed me to kind of grow in those relationships. And they've been so instrumental to my success and also my peace of mind and who I am as a person, and still, being able to be a mom and a clinician and everything else that I do.
All right. Good morning and hello, everyone, and welcome to BackTable Uro, your source for all things urology. I'm your host, Michelle Van Kuiken, hosting for the Society of Women in Urology in BackTable collaboration. My guest today is Marisa Clifton. She's an associate professor of urology at the Johns Hopkins School of Medicine. Additionally, Dr. Clifton is the associate chief medical officer and the interim chief medical informatics officer for Johns Hopkins Hospital. She is director of women's health at the Brady Urological Institute and is fellowship trained and board certified in urology with subspecialty certification in urogynecology and reconstructive pelvic surgery. She's also the secretary of the Mid-Atlantic section of the American Urologic Association and is the chair of the Medical Student Education. She serves as an associate editor of the Journal of Urology Open Plus. Dr. Clifton received her medical degree from the Johns Hopkins University School of Medicine and completed her residency in urology at the Mayo Clinic in Rochester, Minnesota. She finished her fellowship in urogynecology and reconstructive pelvic surgery at the Cleveland Clinic in Cleveland. Her research interests include medical education, female sexual dysfunction, and safety and quality. So thank you so much for joining me today, Marisa. It's really nice to see you.
Well, thank you, Michelle, for having me. I really appreciate it.
Yeah, we're so excited to have this conversation with you today. I know you're a very requested guest, and I'm excited to learn more from you.
I wish I had all the answers. I'm not sure that I do yet, so I'm still working on it.
Well, good. Even some answers will be helpful for us today. So my first question for you is, you currently serve as the Associate Chief Medical Officer at Johns Hopkins, and just tell us a little bit about your path from clinical medicine to your current role as the Associate CMO, and what inspired this transition?
Well, I think that's a great question. So I actually had no idea what I wanted to do when I grew up. And as you highlighted, I did a urology residency at Mayo. And I really enjoyed it. I thought I was going to go into clinical urology and that was going to be it. And then I saw a lot of women and I said, I think I need a little bit more training. And I did FPMRS, now ERPS, at the Cleveland Clinic. And I have to tell you, these are very formative times for us. I think you go at first and you think, this is what my life is going to be. This is who I'm going to be. And then it keeps evolving and changing. And so I actually thought I'd graduate, I'd do privatemics. I joined a great group. And while I was there, I became the residency program director. And then I was recruited to Hopkins and joined and was the urology residency program director. And then I got a really interesting role, kind of a twofer. When I showed through the door, it was for quality and safety. So I became the vice chair for quality and safety and service for the Department of Urology. And so it was, a lot going from more of a private practice focus to a super academic institution. And through all of these experiences, I kind of started to figure out what I liked and what maybe I was better at and what was piquing my interest. So I thought I was going to be a medical educator and that was going to be what I was going to do. And so I was really passionate about the residency program and I thought I did a good job educating, but then I really found what I like to do is kind of build programs and kind of start things and see them through to completion. So we did a lot of revamping of the residency program. I was really lucky to have wonderful mentors that allowed me to kind of try some new things with a very established residency program. So Alan Parton was very instrumental. And then Dr. Mo Olaf, who is the current chair of urology, they kind of allowed me to spread my wings in a certain sense. So I added a little bit of small tweaking to the program and was really excited where it started to go. But then while I was doing that, I was doing safety and quality for the department, started thinking about safety and quality metrics, and then a little bit more operations. And then the ACMO job popped up. And originally it was for patient safety and quality, but then it became a little bit more in medical affairs. And then I started doing operations. So the role actually became more flexible. And part of it was COVID, right? Because we were going through a lot of changes, but they also needed people that could sit and do some of this work competently. And I'm really into kind of designing programs, creating infrastructure and accountability. And so I started to do that well. And then it allowed me to do other things. And then most recently, like you highlighted, I started doing informatics. I actually didn't really know what informatics was, but there was a need for clinical communication updates. And so I figured, hey, I may not be the expert in the content, but I know how to create a team. I know how to build a team. I know how to support missions. And so I started doing some of that, and it really started to synergize with some of the efforts of the health system. So I started to be on health system work groups, and then really have tried to improve the way we communicate, knowing that we as physicians are getting a lot of message noise, and how do we kind of counteract that? So we have been doing a lot of exciting work together. And so again, I'm right now in a very different space than I was when I started training. And I think the key is paying attention and kind of seeing what your skill set is, and grabbing opportunities. I'm not going to stay in informatics. I'm not going to be the CMIO forever. I'm actually planning to probably go down the CMO route, which is really exciting to me. And it allows me to use a lot of my skills. And I think for the benefit of our patients, but really for the benefit of our faculty and our staff being at the table. So that's a little bit about my journey, but it sounded really fast, but it was a lot of work. It took a long time.
Yeah, I mean, you mentioned a lot of these, skills in these roles, the ability to build programs, to create teams. And what other, education have you obtained to get where you are? And do you think it's necessary to have any other formal education, such as an MBA or a master's in health administration? What other skills and learnings do you think are necessary?
So I am one of the few that don't have formal degrees. I don't have an MBA. I don't have an MHA. And I think you can go that route. I do think some of those trainings get you through the door. They open a door for you sometimes. I mean, a lot of it was people knew who I was and that I got things done, and they wanted me to be part of the team, but it did take extra effort. And I think sometimes when you're applying, especially outside of your institution, having those 3 letters can be very helpful. Now, what I would suggest is if you don't know what route to go, talk to people that are in those positions. One of my best mentors and sponsors, he is the CMO for the health system. And, he doesn't have an MBA either, but he did do some coursework. So a lot of us at academic institutions have some flexibility to maybe do a course here or there. We have the Carey Business School at Johns Hopkins. So I was able to do a couple of different courses to augment maybe where I saw some of my deficits. So I think all of us in education get a lot of management experience. So we may not need courses directed towards that, but the financial pieces, Maryland is in a very interesting environment in terms of healthcare reimbursement. So I had to do a little bit of additional kind of thinking about the GBR, learning about how our hospitals reimburse compared to others. So I took some time to take those classes. So I think figuring out what you're good at is great. But I think focusing your training, especially if you're not sure you're committed to an executive route, could be really helpful. And then you can augment, and really it's about speaking the language. A lot of this may not be content, but it's how do you communicate with others at the table so that you sound knowledgeable. And I think those courses really help with that. I think the other piece of this is looking at opportunities within your institution. So I've actually done a fair amount of executive leadership classes within our institution, but also beyond at the AUA. And I think when you tap into that, not only do you get content and you maybe grow, but you also get networking. And so much I didn't realize when I first started is about the networking that gets you to the next step and the next step and the next step. And socializing beyond just urology, because I have a hospital job, I'm socializing with a lot more individuals. So kind of getting your feet wet in the urology world, but then expanding beyond, I think is really key to be successful. And so find those opportunities, figure out where you can network, things that are affordable, don't break the bank, but things that are going to be useful to you. And you have to be really strategic, I think, because our time is valuable. We're doing administration, but we're also trying to educate learners. And then we're also, doing everything else in clinical practice and beyond and research. And so you have to be very strategic in what you decide to do.
Yeah, and that actually leads me nicely into the next question. We're asking about, mentorship and sponsorship. And did you have any mentors specifically who, guided you and inspired you along this journey? And how did you find them and what role did they play?
That is such an important question. And I think I struggled at first when my trajectory changed a little bit. you classically think of like the chairs, and my chairs have been mentors to me, the people that have educated you, at Mayo. I had wonderful educators and Cleveland Clinic, Howard Goldman, who is a ERPS practitioner as well. He does safety and quality, so I would bounce ideas off of him. There are a lot of people that you meet along the way, but being a urologist and going down the hospital side of things, you realize you don't have a lot of people that necessarily follow your trajectory or choose the same path. So it was a little isolating at first, saying, how do I break into this, knowing that not many people have kind of gone the CMO route from urology? I mean, there are some, but they're throughout the country and they're pretty sparse. And so I actually had to learn how to find mentors and sponsors outside of what I did. And it has been, just a wonderful experience. I alluded to the health system CMO that I'm very close to. He's wonderful. He's very forgiving when I make mistakes or I'm a little too spicy. Really has been a great partner in helping me grow, but he's an emergency medicine physician. One of my very, very best friends is actually a lawyer. And so he's risk management, quality and safety. And he gives me a lot of great institutional advice in addition to regulatory advice and the work that we do together. And then I have just a fantastic sponsor who's an otolaryngologist. He was an ACMO before me, and he actually has helped get me job interviews for my next step, thinking about how to kind of expand what I'm doing now. And it's just been really, really wonderful. So I think the key is you're probably not going to find that exact person that's going to be your sponsor for everything. I think you need those people in your life that can be the sounding board when you're having a bad day. And I've got some wonderful colleagues from across the country that I phone a friend when I'm stuck, and they give me amazing advice. And some of them are in private practice, some are in academics. My partner, my husband, is wonderful. He was out in the business world, so he gives me that grounding that I need sometimes when I get lost in my thoughts. I think taking the pieces and the strengths from those around you and learning from them is so, so important. And I think I've become a better leader because I don't just rely on one mentor or sponsor. I'm looking at those around me and I'm saying, what do they do well? What are their skills? What can I learn from them? But importantly, how can I help them too? It's a reciprocal relationship. And that's how you kind of foster that growth is sometimes, they need the advice or the next step, and you can be that phone a friend. And that's really allowed me to kind of grow in those relationships. And they've been so instrumental to my success and also my peace of mind and who I am as a person, and still, being able to be a mom and a clinician and everything else that I do. So I would just say be open to it and really kind of pay attention to who's around you. There are a lot of amazing, smart, wonderful people that you're working with, and tap into it and then help them. And because you can help each other together, it's really been a big part of growth. And I didn't really understand it at first when I started out.
Yeah, that's amazing. You've developed this really cool team and network of, mentors, sponsors, and it sounds like, friends, colleagues that have really supported you in this journey. It sounds awesome.
Yeah, all the above.
I would love to hear a little bit more about, what a typical day or week looks like you balancing, both your role as, the associate CMO and as a surgeon. What does that look like?
That is a really important question, because something else that maybe a lot of people don't think about is how does being an administrator, I don't like the word administrator, but how does being a hospital leader affect what you do every day? And at the end of the day, there was a point where I was the residency program director. We had lost our coordinator. I was also the coordinator. I was the ACMO of the hospital. I was running an FPMRS program, and I was a parent to a new teenager. All of these things were kind of adding up at once. And what you do realize is you cannot do it all. And if you do try to do it all, sometimes you spread yourself so thin. So it was really a big transition point to me, was kind of thinking, where do I want to end up? Because you start to just feel the weight of everything that you're doing, and it kind of creeps up on you all of a sudden. And I think that point in my life was a really important growth point, because I had to give up some of the things that I loved. I loved being a residency program director, but I knew that that wasn't where I was going to end up. I saw this vision. I loved what I had accomplished with my team and with my learners, but I needed to move on. And so with that, you have to kind of be very thoughtful about how you approach things. I also trained at Mayo, big, huge surgeries. We like to do big operations. But when you are starting to be more administrative, you have to be reliable. We all know with the big cases and the big surgeries and the combo cases, they can really affect your availability. And yes, patients come first. I truly, truly believe that. But if you want to be available to have a seat at the table, to be reliable, you have to sometimes make compromises in what your clinical practice looks like. So I was very conscious to kind of move towards an outpatient type of surgical practice. Now, it worked out well for me because being at an academic institution that's very oncology focused, they need a general urologist. So I got to do the stones, the small procedures, the female urology that wasn't big, but that allowed me to have more of that manageable schedule so that I could keep my sanity
Yeah.
and make sure that I was in focus. So I had to be very deliberate in kind of that transition. And it was hard because you're used to doing the big cases. You think this is what it means to be a surgeon, and you do get comments. You trained this. I had a patient tell me, well, you've trained so hard. You've worked so long. Why would you give it up to sit at, the administrative table to kind of separate yourself from that? And I think we'll talk about this a little bit later, but you have to make some of those conscious decisions. So as ACMO, I actually am about 45% administrative and 55% clinical. Now, if you go down the route of hospital leadership, that administrative time is going to be even larger. And then you're going to be close to maybe 20% clinical, maybe even 10% clinical. And you have to decide, is that a step that I want to take? And is that going to work well for me? And I didn't think about it. When I was first thinking, I'll be a CMO, and then I'll run this clinical practice. But that's actually not how it works. You've got to have the time. You don't know when the regulators are going to drop by for a site visit. You don't know when there's going to be a big problem like an IV fluid shortage. So you have to kind of start to think along those lines. And what is my clinical practice going to be like? And so now it's about half and half, but really it's about 100% and 100%. And you have to kind of plan for the future if you're going to take bigger steps in that direction. So now I do procedures. I do have OR every other week, and I do have quite a bit of clinic, and I read urodynamics for the department. So I do have a pretty big clinical footprint, but I know the next steps down the road may make that footprint even more small.
And talking a little bit more about that role as, associate CMO, and as you've kind of declined in your clinical practice and gained this greater administrative role, what about that leadership role brings you joy? What do you enjoy about it? What fuels that passion that you have for this work?
Well, I think that part of the reason I went down this pathway is that I want to make things better. I think anyone that's met me and knows me, I get frustrated if there's a problem and we don't come up with a solution. And I think there are certain elements of clinical practice that are very frustrating to a lot of us, whether it be prior authorization, scheduling, the turnover of our mocks and secretaries or administrative support, the fact that we can't see the patients that we need to see as urologists, and we see a lot of maybe outpatient office patients. There are all these little things that became kind of frustrating to me. And then, being in a big academic center, you don't always have a voice. You sit there, you want to change things, and you can't change them. And so I found myself spinning my wheels. And I know that, Mo Alaf has had to hear me talk through this several times. But you want to make things better. But what I was able to find is that when I stepped outside of my little space and I opened to a broader perspective, I found out there was a lot that needed to be done and I could help do it. So when it started being medical education, I started doing more work in GME. When it was safety and quality, I had a huge drive to kind of deal with some of those big issues that were at the cusp of kind of becoming major problems. And so I was able to take that energy that I had pent up in my little clinical space and use it for productive outcomes. So now, when you look at your administrative board and who's at the table, you may see a lot of clinically based team members, but a lot of them aren't surgeons. And I feel like we started making some decisions that were really kind of excluding the perspective of maybe one of the most important parts of a hospital, the surgeons. And so now I get to sit at the table and say, hey, it actually doesn't make sense for us to have a CAUTI policy where you're pulling out catheters on our urology patients. And they hadn't thought about that. So you're able to bring this very unique perspective. And so I get really excited about that. I also get excited when I close things, when we do a project, when we make the change. A lot of people have feelings about secure chat and MyChart messaging and Epic, but I'm going to tell you, if you can do that in a thoughtful way so that the volume of message noise goes down for your prescribers, and you sit at the table and say, that's not reasonable, let's not go that route, but we've got this great other pathway we can go, you really feel like you're protecting your staff and your faculty. And so I think what gets me really excited is making things better, being part of the change, being able to really see a project close and know that it's going to not just impact me in my clinical practice or my partners in urology, it's going to impact everyone and hopefully for the better.
Yeah, I love that. I feel that, be the change energy. And I think it's really important that you have that seat at the table and are working to make things better for, for surgeons and for other physicians. And this, as you mentioned, like the whole team, the staff as well. I think there's a lot that needs to be changed. And so I think it's awesome that you're, have a seat at the table. Can you discuss any challenges that you experienced, on your way to this role and how you worked through them? And have there been any specific challenges that you feel like you faced as a woman in particular?
Well, every day there's a challenge and you actually don't know what's going to hit you. So when I first started training, I was pretty rigid. Everything was black and white, right and wrong. And it's amazing as you kind of get this experience, you learn kind of the gray. And I don't mean that in a bad way. If you had asked me 20 years ago what I would think that, like, no, right and wrong. But actually, there are a lot of nuances to everything that you do. And so as I've been in a leadership role, you start to see that there are many sides to every story. So I was just used to being the clinician sitting there focused on my patient and everything else was just kind of in the background and not right if I didn't agree with it. What you start to see are all of these other things that contribute to the situation. And you start to be a much better listener. And you also have to go into a problem having done a lot of research. And I think being a program director set me up for that. When you have a problem that, faces your learners or you really have to step back and kind of look at everything because otherwise you're going to miss an important stakeholder or perspective. And then you're going to change something and then people are going to get upset. And then that upset feeling is going to be projected onto you and it can kind of snowball really quickly. So I would say I made a lot of mistakes and there's nothing that I can say. I'm not a perfect person, but I think trying to take each opportunity to learn from that mistake and trying to be better. I used to be a pretty spicy surgeon. I think a lot of us that are listening are surgeons. We have a very black and white kind of mentality. We have to make decisions. And so it took a lot of self-regulation and mentorship to kind of get me past some of those points to get to the long game, to understand that delayed gratification. We've been waiting so long in clinical practice, to get started and get exactly what we want. When you start leading groups, you really have to wait. You have to be very deliberate in your decisions and what you say. And that's been a lot of growth. And I could tell you every day I face a situation that I didn't think I would have to face. And I always think, how can this be happening? A little bit like parenting, like when my kids one day they decided to dig a hole and rip out all the plaster on the wall. And I was like, why would they do that? I would have never projected that this could possibly happen. But it's a little bit like that when you're in the hospital setting. You're like, someone did what today? And I'm going to have to deal with this today. Okay, who are my stakeholders? What additional information do I need to get? How am I going to synthesize this? How do I have my meeting before the meeting, before the meeting, before the meeting, and then sit at the table and talk about this? It's a lot of strategy. And I think every time I think I've communicated well, I find out I haven't communicated as well as I thought. And in a big quaternary hospital system, you can send emails, you can have meetings, you can go to the meetings, you can tell their bosses, you can tell their boss's boss. That doesn't mean that's gotten to the individual prescriber. And so I'm constantly learning. It's constantly a growth opportunity, but I also think sometimes you just have to throw away the nonsense. There are people that are going to disagree with what you do, no matter what you try, no matter how many times you talk to them. And you just have to sometimes say, I made the calculated decision. This is a choice that I've made. This is the choice we've made, and we're going to stick with it. And we understand not everyone's going to be happy with it. And I think those, I can't give every example along the way because honestly, it's daily. But those kind of growth mentality thoughts help you get through those really challenging situations. And you will make mistakes. I mean, I think you talk to my residents and they'll say, hey, she made mistakes. You could talk to my boss. Mo would tell you she's made mistakes. You could talk to my hospital boss and Peter and Carrie will say she's made mistakes. But the key is that you learn from them, you grow, and you try to have a very broad understanding of the situation before you start making decisions.
Awesome. And I think that's such an important, instead of dwelling on those mistakes and thinking, I did something wrong, it's like, but how can I learn from that and move on? And I think as, I know I'm the associate program director in my residency program. And I think that idea, I always try to tell the residents, it's about, we all make mistakes, but how do we learn from them? How can we move on? And I think that's such an important, skill set to have.
Oh, and I have negative thoughts all the time. I mean, I don't want to say that I've gotten over that. That's probably something I still need to work on. I need to give myself a little more grace than I do, and I need to not perseverate because it really does kind of create a negative spiral. But I think part of being successful is I'm always thinking about those things. But then that flip side is sometimes it can impact things outside of your work, like your family life or your friendships.
Right.
And you have to be very conscious to try to prevent that. And not all the time am I very successful at that.
It's very, very hard. So it sounds like you're doing well though. And I think it's something, particularly as women, I think that we internalize these things a lot too. So I think a lot of room for all of us to grow in that arena. If you could change one thing about the intersection of clinical medicine and hospital administration, what would it be? Or what's something that you found particularly challenging?
There are a lot of challenging intersections. The one thing that I've really struggled with is how difficult everything is. Clinical medicine, you want to be able to make some meaningful change, and it takes a little bit of investment. And I think some of the most successful practices I've seen, there's been this focus on the future and the investing in the time, the personnel, and the resources to be successful. I feel like working in the hospital setting, especially in the current climate, everyone's pretty strapped for energy, for cash, for resources. And what I'm trying to do is really focus on making it more than just trying to get by. I really dislike the everything's on fire mentality. I'm a very my dad's a risk manager. I'm a very kind of, we need to plan for this, we need to prepare, but it does take time, energy, and resources. And you will find when you're sitting at the table, there are so many things that pop up every day that sometimes people lose that vision. And I wish that we could kind of synergize our clinical vision with the administrative vision and be very proactive and deliberate. I always have a couple of projects that no matter how busy the day is, I never forget about because my goalpost is to get them done because it's going to mean a better outcome for our patients, a better working environment for our staff and faculty. And so I'm always focusing on those. But I have to take care of the day-to-day fires. But I think if we could balance that a little bit better and clinicians could be part of the conversation, I also think that a lot of our faculty don't understand the hospital side of things. I certainly didn't. I would like to say I'm in control of technology. I'm actually not. It's under the COO's office. And so if I need to do something with information technology, I've got to work with an entirely different branch to change that. And you would never know that as a clinician because I didn't know that as an administrator until I started getting into the weeds. I just wish we could communicate and understand each other better and then have a more longitudinal, long-term focus and not just be so caught up in the day-to-day. People are not just replaceable. Time is not just replaceable. Institutional knowledge is not just replaceable. It takes a lot of time and energy for those things. And I want to be more proactive and deliberate in how we think about that. So I wish that would change.
Do you have any thoughts about how to improve that communication and understanding between leadership and the practicing clinicians?
That, I think, is the million-dollar question. I think some hospitals and health systems communicate pretty effectively, pretty well. I actually use my nursing colleagues as an example at Hopkins just because they've actually created lines of communication that ensures that the information from the chief nursing officer gets all the way back to those at the bedside, almost, pretty reliably. We don't do that as well on the physician side, and we really struggle, or the advanced practice side. And so I actually use them as a little bit of a model for that. But really, when you're talking about how do we kind of improve it, I think number one is having administrators have a clinical presence. People have asked me, are you going to give up your clinical practice? I firmly believe no. And I also don't ask for things beyond the other faculty. When I'm a urologist in the department, I think most people would say she's a urologist in the department. They don't look at me as someone who's like hospital leadership. They say, okay, that's Marisa. She runs, female urology over at Bayview. But I think it's so important because number one, people see you doing the work. So you can get some credibility I may not have all the credibility, but you get some. But also you start to understand the pain points. And if you're never clinically present, or if you're clinically present with a very special practice, you tend to lose sight of the day-to-day issues that people have to struggle with. And so I don't think I'm ever going to give up clinical practice. I'm always going to want that to be part of it. And I think you have to lead by example. I wouldn't expect anyone I work with to be held to a different level than myself. And so if I'm holding someone to a level of productivity or expectation, I'm going to expect that for myself. So if I don't close my notes on time, I expect my boss to yell at me. Well, he would never yell, but I'm just saying I expect to be held to the same clinical standards. And I think that's really, really important. So yes, you can have modes of communication that are better because you have a better, well-oiled machine. But I think other aspect of it is being clinically present, boots on the ground, and not expecting something that others don't have.
Yeah, that all makes a lot of sense. I think one of the complaints we hear a lot is about the people making decisions about clinical practice are oftentimes not present. And I think people feel that frustration with, well, how are they making these decisions and arriving at these conclusions and creating these changes that are impacting my work when I never see these people and I don't interact with them. So I agree. I think having that, that real face time and interaction, I think is really important. And showing up and being present is, I think, at least a small part of the battle.
Well, and the other thing that you just kind of alluded to is that I'm not going to know everything about every space. So as urologists, I think we're uniquely poised to be in leadership positions, right? We have clinical presence, procedural presence, OR presence. We work in the ER, we work in ambulatory. I have a footprint in a lot of these places that we're helping manage. That being said, don't think that you know everything. I think people have a downfall in the sense that they're overly confident in how much they understand a clinical space. And actually, some of my biggest failures have been where I thought I knew the right way to approach this problem. And I hadn't done that background research and communication that I needed to make the best decision for the teams. And so I find myself having to balance what I think I know, my perceived understanding, and making sure that I really have the stakeholders at the table and I've had that open communication, because that's really where you can, screw up. Because I don't do cardiac surgery. So if I thought I understood all of the nuances of the ECMO team and this team and that team and the ICU integration, I think that's where you could really kind of get yourself into trouble. So
Yeah.
stepping back and also saying, hey, I may know some, but make sure I don't misinterpret that situation is really important.
Yeah, but also really engaging the stakeholders in that
Yeah.
space to make sure that they have their seat at the table and are making their voices heard.
Absolutely.
So, Marissa, I was wanting to shift directions just a little bit and just spend some time talking about, leadership development and developing that executive presence. I know you've completed the AUA leadership course just recently, and how would you describe your experience in that program? How would you promote it to those who are interested? And tell me a little bit about what the process was like applying for it and, who would be a good candidate for participating in the program.
Yeah, I think, it's really interesting. So the sections actually help select who goes to the AUA leadership class. And I think there's a different number per section. Stepping back a little bit, I'm just talking about my engagement in urology. I had a wonderful sponsor that I never actually really worked with, Jay Rahman. He worked at an adjacent hospital at Penn State Hershey, and I was at Geisinger. And he actually was a real huge supporter of me. He said, this lady is a little bit feisty. I like her spirit. Let's see what we can do. And he actually started kind of getting me more engaged in the Mid-Atlantic section. And so I stepped back a little bit because I think there's a lot of opportunity in your sections and different committees and in, your professional organizations. Like we have SUFU. I kind of made a conscious choice maybe not to spend as much effort over on that side and more on the AUA side. Again, you have to be strategic about where you want to end up and what you want to see your presence as. You can be on a million different committees across a million different organizations, but then sometimes you're spread too thin and you don't get that reputation to be the person that helps get the team together and close the deal. So I actually focus pretty heavily on my work with the Mid-Atlantic section, and it has paid dividends. I've met amazing collaborators. I have just a wonderful team across the Mid-Atlantic that I absolutely love. We have engaged learners. And so I've had these small opportunities along the way to kind of be involved in the section. And then I was able to go on, I'm part of the board, and then I just recently became the secretary of the section. So again, small deliberate choices, but being engaged and kind of thinking through that. So I had an opportunity to be on the AUA leadership class. And I think in part it was because of my involvement in the section, because the section is charged to choose the people that they think would benefit and that, would represent the section, and that will be leaders within the AUA at some point in time. I think that's really, a major focus of it. So I would say if people want to be in the leadership class, certainly apply, but also don't be discouraged if the first round it doesn't work out, because you sometimes need to form those connections. You need to build that presence. And then, honestly, just being thoughtful and deliberate and saying, this is actually a passion of mine. And we've had people that have said, hey, I want to do this. This is what I want to do. And maybe they didn't get it the first go around or even the second, but then they got on that third time. And I think they want to see that initiative and that drive to join that program. So I would say, try to find maybe your section organizational structure and see what's available, what committees, what can you be part of? Can you participate in the section meeting? Can you help plan? Can you help organize? I'm not going to lie, I did a lot of kind of busy work. I actually helped rewrite the bylaws. Most people would think that's pretty boring, but I'm pretty, minutia based. So I was able to go through it, and it was very helpful to the section, just small little things to kind of move you on. But anyway, I think it's a great opportunity. And I also think it allows you to network beyond your specialty. I'm female urology, so I know a lot of female urologists like yourself, but you don't always think about being with the oncologist or maybe the GERS team or endourologist. And having some of these opportunities allow you to kind of expand beyond. So sitting at the board, I'm with oncologists, GERS, peds, every specialty. And that really kind of expands that footprint. And the AUA leadership allows you to do that as well, because they pair you for different projects. And so you have a chance to meet people across the US that you maybe wouldn't normally collaborate with, that have actually been wonderful mentors to me and colleagues. And we've partnered on things beyond just the AUA leadership class. So I think the question is, who's the right person to be part of it? I think anyone that's interested. I think it was wonderful to meet people across the section, but I think it's kind of the early and mid-career that's really what the AUA leadership class is about. But some of the more senior faculty, I think, have decided to do it to be part of it. So I think anyone could do it, but don't be discouraged if you don't get it the first round. And then also think, well, I didn't get it this round, or I didn't have time to apply this year. Think about how you can engage in your section or with the AUA in general. And I found that they're very, very receptive to have people come along and say, hey, I have a new idea. Can we try this out? I'll put in the effort. And I think the key is just putting in the effort yourself, knowing that you're not going to probably have a ton of resources to kind of do something outside, but they're very willing to collaborate. So I found that experience really great. And then I'm actually doing the master class this spring. It unfortunately conflicts with SUFU, but it's, I'm really excited about it. And it's going to be a new group of people that I'll be able to network with. And then experts in the AUA, like the president, Steve Nakata, and then Jay Rahman. And that you get to kind of get a sense of how that organization works and hopefully continue to grow my skill set.
Awesome. Well, that's great advice, particularly about involvement in the sections. I think you're right. I think some people don't always think about that as sort of a next potential stepping stone in their leadership development and gaining opportunities. So I think that's really, really great advice. And along the way, have you worked with a coach? And what was your experience like with that?
So I think a lot of us have had coaches, and I've had several different opportunities. So when I did my executive leadership development course at Hopkins Medicine, they have their own kind of team of coaches. And the interesting thing about that course was that it was maybe even divisional directors all the way up to hospital leadership and even beyond. So we had non-physicians that were part of that team. So you actually had a very heterogeneous group. And so the coaches had to somehow coach people at various levels, and we did group coaching. And you can imagine there are some that have done a lot more focused work, and then there's others that have never worked with a coach before. So that was a little challenging, I think, for the coaches to navigate. They did a great job, but it's hard to know. And then sometimes you need coaches for different things. I think some people struggle being a urologist in a clinical practice and navigating all of, I think, the politics that can come along with the department, or even, if you're part of surgery, how do you navigate that? So there are coaches that are focused on that. There are coaches that are focused on kind of life. Are you having a hard time kind of integrating everything because we have a lot on our plate. So I actually, have tried coaching from that perspective. I'm very lucky because I have a partner that's very supportive of me and very, I think, proud of my accomplishments. And so he takes on a majority of the childcare and all the responsibilities. It has allowed me to kind of focus on my career and my passion. But I think others benefit, from having that coaching perspective for how do we navigate the day-to-day in a complex relationship where you're a successful woman or a successful leader and you've got these constant pulls. My current coach is actually, she works at Duke. She's in charge of HR. Her name is Rhonda Brandon, and she's phenomenal. She is someone that is not a physician. She's not Hopkins based. She gives me the perspective of someone else on the leadership table, at the table for a completely different reason. And so she helps me navigate a lot of the challenges that I have coming to the table and interacting with different perspectives on that level. And I think that's been very helpful for right now for what I'm going through because I'm in the process of probably making the next big jump in my career. And she's helped me really kind of understand, how do I think through this problem? How do I navigate the politics of having search committees and interviews and everyone's opinion about what I should be? And so she's been instrumental in probably helping me successfully navigate this next step. But I'm going to say people need to find an area that they want to focus on and then find someone that they mesh well with. And then really learn from that experience, but also not be afraid to try different ways to navigate it with either a different coach or different executives. I have found that it's great, to reach out to people that are in leadership, but like sometimes people send me a cold email. I don't necessarily have an hour time where I can walk them through the pathway. So when you get that coach, you're able to kind of spend that time with that expert and work through it. And there maybe sometimes your department will pay for it. I personally think it's worth it for me to have Rhonda giving me the next steps or the next tricks. Some people invest in themselves, but I think there actually are a lot of funding opportunities through departments if you wanted to go that route. And if you do hospital leadership, there's a lot of opportunity because a lot of these bigger institutions do have a team of people that they contract with that you can work with. And they're wonderful. They really are.
Yeah, that's great. I know even at UCSF, there's some initiatives going on right now to really figure out how can we get access to coaching for more physicians, who want to gain skills in different areas outside of just clinical medicine. And so I think there is a bigger role and bigger push to make that resource more available and oftentimes covered by, the hospital or the institution that you're working at.
Yeah, and I also think there are some individuals that are very passionate about sponsoring, and you likely have seen them out on social media. I know like Phil Perazio has been a wonderful help to me where we were colleagues at Hopkins before he went to UPenn. But, there are a lot of different people that you could tap into to find opportunities to either work through. Some people actually want to go through life coaching training, and that really is very instrumental to their success. And honestly, a lot of hospitals are looking for leaders that are able to coach their team through challenging situations. So it can be a skill, too, that you use as a leader to help. And certainly being a program director, I think being a life coach would have been great. So I think it's a skill that people should think about. And then it also helps you maybe mitigate some of your own burnout.
And that's a really great perspective on, just other skills to gain as well. This conversation has been absolutely incredible. I feel like I'm learning so much from you and I love hearing your perspective. Maybe my last question will really focus on, there's this concept of executive presence. And have you ever taken any courses or gained any skills particularly focused on this idea of executive presence? And is that something that you focused at all on?
So executive presence is very interesting because it's who you are, but it's also the skills that you bring to the table. And I don't think I had a clear understanding at first what I wanted my executive presence to be. And I've wrestled with that over time. Some people are very quiet. Some people aren't, are very kind of straight-faced. They're very thoughtful. They're wonderful leaders, but they have that presence. And I thought to myself, that's what I see. That's what I should be. Well, that is not going to be me. And as Rhonda says, I don't want to dim my light to make people feel more comfortable. You need to be who you are. And I think that was one of the lessons that I only recently learned is everyone is going to have an idea of who you should be, what you should do. But at the end of the day, you have to be true to yourself. Now, it doesn't mean I can't polish myself up and make myself look the best that I am, but I really wrestled with trying to be less of who I was because I've had comments before when I've done interviews like, you're very excited or you seem to be really passionate, as if it was a negative. And I say, well, maybe for your institution or that position, it is a negative, but I am going to be me and I am fully me, but maybe I could be a little more polished. So I do want to tell everyone that you have to stay true to yourself because if you try to be someone else, you're not going to be happy. You're not going to get the right role. It's not going to be the best fit. There are a lot of times that I thought this is where I wanted to be and this is what I had to be. But when you realize what makes you happy about the work you do is being who you are and making that difference, you don't want every opportunity that passes along the way. I've interviewed for some jobs and I was just like, that actually would not be a good job for me. And it didn't mesh. And it was 100% the right thing. It's like when you match a resident. When you're thinking about who do I want to come to my residency program, you don't just want the number one that you want. You want to make sure it's a good fit within your environment, within your faculty, with what you're able to achieve. And I think the same thing comes when you are an executive and you're going into a job. You want it to be the right fit for you. Otherwise, you're going to be really burned out. So I think executive presence is really important, but you got to stay true to who you are. You can refine it though. And I've had to really learn to kind of sit back and listen and not always say things every time I have an opinion. Because my husband will tell you, I have a lot of opinions. My residents will tell you, my boss will tell you, I have a lot of opinions. But part of it is also letting people work through things themselves. And one of the other things about executive presence is realizing that you're going to have to wear different hats. So when I'm running a meeting, I have a very clear idea of how that needs to go. But when I'm meeting one-on-one with those that I am working with or collaborating with, I have to change my hat. I have to meet them where they are. I have to understand what they're trying to get from that interaction. And a lot of times, it's just working through their own thoughts. And so you just sit there and you listen. And sometimes people don't even want you to fix anything. They just want you to hear them. And so you have to build in that time to do that. So I think that's the way that you can really create your executive presence is learning how to come to everyone at their level and understand what they're trying to achieve. And then honestly being transparent about what you can achieve and not achieve. If I can tell you the one thing that was maybe the most meaningful to my success in leadership is that I never promised something I couldn't deliver. I always close the deal. So if someone comes with an ask for me and I say I'm going to do it, I have a running list of things that I owe people and I make sure I check it off the box. And if for some reason an email gets lost, I own that lost email and I say, I'm sorry, this is important. I just overlooked it and I'm going to take care of that right now. And then I put it to the top of my list. And I think if you ask me the one thing that made me successful is making sure that I was trustworthy and that I closed it and then I treat everyone the same way. If I say I'm going to do something, it doesn't matter if, it's a clinical aspect or if it's all the way at the hospital level, I'm going to check that box that I have done it. And following up and circling back has created that relationship. And I think my executive presence. But, the other piece of this is the skills that you bring to the table. You have to know what you're good at, but you also have to know what you're not so good at. And I know what I'm not so good at. And I've got a team of people that can fill in those gaps for me. And they know that I'm going to sponsor them and they're going to help me. And it's a win-win. So executive presence is complex, but I think all of us have it. And I don't think we should lose it for what we think it should be. You should be you and you should use your skills to the fullest and then build your team. And your team is what actually helps you be the most successful.
Well, Marisa, this has been an absolute delight talking to you this morning. I want to give you an opportunity if you have any last thoughts or anything you want to share with everyone before we sign off. But I can't thank you enough. This has just been absolutely a delight.
Well, thanks so much, Rochelle. I just want to thank everyone for the opportunity and also just say I do not have it figured out. I think I said that at the beginning of this hour. I think a lot of how we grow is being open to the fact that there are different ways to do things. And at the age of 42, I'm learning something every single day. And I've had so many smart, wonderful mentors that have helped me. But I also want to say my mentees. I learn a lot from the upcoming generation. And I think as we go into leadership, the last tidbit, besides closing the deal, you always want to close the deal. The last tidbit is we're going to have to think about the future of leadership and urology in the context of the upcoming generations. I think what all of us are used to is going to have to drastically change. And I would encourage everyone to think about what that means. And what it means is, what I kind of put my head down and push through clinical practice and training and everything else, I can't expect that for the person that's coming up. I have to come and meet them at the level that they want and have to understand that I'm going to have to give more of myself to my team members so that my whole team can be successful. And it's going to be a change in perspective. So I would say we need to start thinking about that because it's the only way we're going to retain talent. That's the only way we're going to continue to grow. And I see the future of hospitals struggling because they're going to say, oh, we're just going to keep grinding people out. We need to have a mind shift. And so when you're thinking about your leadership, if you have that lens, I think you're going to be a lot more successful maybe than some because you're focused on how do we retain, how do we recruit, and how do we grow and develop the next generation of leaders.
Well, awesome. Again, thank you so much for joining us today. This has been really incredible. And I'm looking forward to hopefully seeing you in person again, maybe at the AUA. It sounds like maybe our next meeting.
I'll be at the AUA for sure. And hopefully a lot listening to the podcast will join too.
Yeah, well, thanks to everyone who's listening today. Again, it's been wonderful chatting with you, and we'll look forward to our next episode.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.